My name is Richard Barth. I am an orthopedic hand surgeon, and thank you for joining us tonight for this seminar. I'll be presenting with my partner, Dr. David Moss, who is also an orthopedic hand surgeon. We both work at Washington Orthopedics and Sports Medicine. We are both orthopedic surgeons who specialize in surgery of the hand and upper extremity, which means we take care of problems that go from the shoulder down to the hand. Our charge tonight is to talk about problems and pain and disability in the hand and wrist, how we treat it, how we evaluate it. And so Dr. Moss and I have divided this up. I will be talking about arthritis and tendonitis, and Dr. Moss will be talking about nerve problems. Before I get started, a couple of housekeeping issues. We are going to each give a presentation, and then I will give a presentation, Dr. Moss will give a presentation, and then we will answer questions afterwards. I've been asked to ask you to use the Q&A tab and not the chat tab. We'll be monitoring the Q&A tab. So I'm going to get started, and I'm going to talk about, first of all, arthritis of the hand and wrist, evaluation and treatment. So I'm going to cover what is arthritis, who gets arthritis, what causes it, what are the signs and symptoms, the diagnosis, prevention, treatment. And I'm going to start with what is arthritis. I see patients every week who come into me and say, I have arthritis, but I really don't even know what it is, but I think I have arthritis. Well, arthritis, very simply, is that your joint is wearing out. And the way I like to explain it to patients is that the joints are like the brake pads in your car. When you get your new car, your brake pads are perfect. As you drive them, they start to wear out. And that's kind of how arthritis is. You're born with this beautiful cartilage, and if you look at the picture on the left that says normal, that's a picture that shows a normal joint, and that white material with the arrow pointing towards it is the cartilage, and it's a cushion that allows your joints to work and function well. When they wear out, you get to the point where it looks like it does in the picture on the right, where all that beautiful white cartilage is gone, and you have bone rubbing against bone. And basically that's what arthritis is. Your cartilage on your joint has worn out, and you have bone rubbing against bone, and it causes pain and swelling and deformity. So my slide here got a little messed up, but this is a normal joint space, an x-ray that shows a normal joint space. And you can see the white is bone, and the black spaces between the bone are cartilage. And if you look, that's all perfect and beautiful and symmetrical, and that's a normal joint. As you get arthritis, it starts to look like this, where you have bone rubbing against bone. The beautiful cartilage is gone, and you can see that the bone is just rubbing against the bone. And this is what an x-ray of arthritis looks like. So this is a person with the typical wear and tear osteoarthritis that we see every day. And you can see the fingers are a little bit deformed and crooked. There's nodules. And if you looked at an x-ray of this, there would be bone rubbing against bone, and there would be deformity on the x-ray. So this is a typical appearance of arthritis of the hands. So I'm going to talk about who gets arthritis. Probably the single most important factor is increasing age. As we grow up, our cartilage wears, and you have less and less, and you get arthritis. I highlighted family history here because particularly in the hands, most patients with arthritis will have a family history of arthritis in their hands. So when I see a younger person in their 40s or 50s with arthritis in their hands, and I ask them, does your mother or father have arthritis? And usually they've already volunteered it, or they'll tell me that they do have a relative, a father or mother who has it. And there's a very strong family history of arthritis in the hands. There are high-risk hobbies and jobs. Any hobby or job where you beat up your hand is going to give you a higher chance of getting arthritis. your job involves operating a jackhammer, you played rugby until you're 50, you're going to beat up your hands, you're more likely to get arthritis. The next factor is a history of injury. And so when someone is a young person and playing sports and damages their joint, it'll often settle down and be fine for a while, but they've damaged some of that cartilage. And over time, that damaged cartilage will wear faster. And so a history of a significant joint injury as a young person can predispose you to getting arthritis. Arthritis is also associated with obesity, and women get arthritis in the hand much more than men as well. So what causes arthritis? Arthritis can be caused by a number of things. Number one, and the most common cause of arthritis is just the wear and tear of growing up. And that's the generic osteoarthritis or arthritis that most people get. As I mentioned earlier, there's often a genetic or family history. And as you grow up, it gets more and more common. You can get arthritis, as I mentioned earlier, from an injury. An infection can result in arthritis. When you have an infection, the joints get filled with inflammatory cells, and those inflammatory cells can damage the joint surface. And another common cause is the so-called inflammatory arthritis, such as lupus arthritis or psoriatic arthritis or rheumatoid arthritis. And all of these conditions, the person's immune system and white cells will attack the joint and damage the joint. So this is another common cause of arthritis. So what are the signs and symptoms? I showed you a picture of someone with deformed, thick joints, pain, swelling, stiffness. The joints can get stiff and you can lose motion. Generally, the pain is better with activity. Pain is worse with activity and better with rest. And it will often wax and wane, but generally it gets worse over time. How do we make the diagnosis? Well, the diagnosis is almost entirely made by your history and physical exam. People will give a classic history, which we've discussed earlier. The physical findings are usually pretty clear to the people who take care of patients with these problems. And so most of the time, history and physical are almost all we need. We usually will get x-rays to confirm the diagnosis. Patients often ask us, don't you need an MRI, or shouldn't we get an MRI? And an MRI is almost never needed for someone who has routine arthritis. We'll sometimes get blood tests if we think it's an inflammatory arthritis or maybe some type of infectious arthritis. But generally, blood tests are also very rarely needed. I'm going to touch next on how we treat arthritis, and I'm going to go through the litany of options that we have. First of all, prevention. Would be very nice to completely prevent arthritis. Unfortunately, it's hard for us to not grow up in age. But what you can do is avoid injuries. A significant injury to a joint can predispose you to arthritis. Maintain a healthy weight and a healthy diet. Exercise regularly. And I put rest on here, not that you should rest, but that you should rest the arthritic joints. I have patients who come in with those gripping machines and tell me that they want to keep using these gripping machines so that they can keep the arthritis from getting worse. And you're better off resting arthritic joints rather than beating them up by doing things that maybe you don't need to do. Okay, heat and cold. I generally recommend heat in the morning when you get up, heat when you're stiff, paraffin bath, hot packs, hot shower, and then ice after you do something. So if you have arthritic hands or thumbs and you go out and play tennis or do yard work and your hands are swollen, then you use ice. But I find that heat in the morning, a paraffin bath helps, and then ice afterwards. I have patients who tell me, no, for me, it's better to use the heat after I exercise and ice in the morning. If it works for you that way, that's fine. But generally, I find heat in the early and then ice after you do something. So the other things we can use to treat arthritis are anti-inflammatories. Anti-inflammatories include Motrin, Advil, Aleve, things like that. And they are effective at controlling the symptoms and keeping the pain and swelling down. We generally, for the hand, don't prescribe them around the clock, but more on an as-needed basis. There are other medications that are used for an inflammatory arthritis. If you have lupus or rheumatoid arthritis, there's a whole different class of drugs that one would use, but those aren't used for routine arthritis. And then splinting can often help. If you have an arthritic wrist or thumb, a splint will help settle things down. Visco supplement injections. Many people have had injections into their knees with visco supplements like Synvisc or Gel 1, and there's a whole slew of them. And they've been shown in the knees to be effective. So we use them a lot in the knees, but in the hands, the studies have been more inconclusive. So it's not really a standard treatment for the hands or the thumbs, but occasionally patients want to try this and will sometimes use it, but generally it's not been proven to be effective. Cortisone injections are effective when used judiciously. Cortisone works very well at settling things down. The problem is it tricks you into thinking you're okay and that you don't have arthritis, and then you end up beating up your hands or thumbs or fingers worse. So we don't like to inject joints very often, and I mean, we probably each of us have our own number or frequency, but my feeling is in a joint, you don't want to inject it more than a couple of times. I think after that, you start doing more harm than good. Occupational therapy. There are some studies that show that people who have arthritis and go to see a hand therapist, they find some benefit to that. It probably doesn't affect your arthritis, but it may help with adaptive aids, some things you can do to maybe do things differently so it doesn't affect your arthritis as much. So I'll sometimes send patients for a short course of therapy. I don't send people to therapy for months and months with arthritis. Acupuncture, I've had patients tell me has helped them. It again is not one of my standard treatments, but if somebody comes to me and said, I've had acupuncture, it's worked for other problems, I don't object, but I don't think there's a lot of data that it really helps arthritis. And then vitamins and supplements, things like glucosamine, turmeric are things that some patients have found helpful. Again, there's not a lot of data that they provide long-term relief. The last option for arthritis is surgery. And surgery for arthritis in the hand and wrist is a last resort. And we do it when patients tell us they don't want to live with it anymore, excuse me, and they're willing to have an operation. It would be very rare for us to say, you have arthritis and you need to have surgery. So this is really driven by the patient. So for arthritis of the thumb, we see this very frequently, and there's a very, very good operation for this. It works well. It's a little bit of a nuisance for patients for a couple of months, but most patients are very happy they've had it done when they choose to do it. The slide on the right, you can see a normal joint, and we saw this earlier, beautiful cartilage on the left, the arthritic thumb. And then here's someone who's had surgery, and you can see the slide on the right. There's a space. We take out that arthritic bone, and the picture on the left, you can see we've woven a tendon through there to suspend it and create a new cushion for the thumb. And this operation has been done for 30, 40 years. It's very effective, and it's predictable, and most patients do very well. Here's an X-ray side by side. On the right, you can see somebody with an arthritic thumb, bone on bone, big bone spurs. On the left, You can see the bone has been taken out, and it looks like it's suspended there, but it's really, there's a tendon holding it in this position. And since we don't use a prosthesis, this generally tends to last forever. The MP joints of the hand, these are the joints where your fingers meet your hand. And as you can see, where there's a blue and red arrow, we have some arthritis. When patients have arthritis here and they choose not to live with it anymore because it's so painful, we can replace this joint. And the picture on the left shows a joint replacement for an MP joint. And we don't do these very often, but they're fairly effective and most patients do very well. Here's this patient who had that arthroplasty. The ring that you see on the ring finger is for a different problem. I think you can see barely the scar on the back of her middle finger, her long finger. And the picture on the right shows her motion. And this operation generally works very well on the correctly selected patient. When patients have arthritis of their PIP joints, which are the joints that I'm going to show you here, are these joints. PIP arthritis is managed either with a fusion, which means we lock the joint in place, or an arthroplasty, which means we replace the knuckle. And so here's a picture here of someone with arthritis in their fingers on the left. And on the right, I've done a replacement of the knuckles with metal implants. And I think you can see they're well aligned, and these patients generally do well, although these type of arthroplasties are nowhere near as predictable as hip or knees. And you can see that I fused a couple of the other joints where there's a screw in there. For the DIP joint, and the DIP joint is it's this joint, the end joint out here. I don't know if you can see me, but that joint we manage with a fusion. And the way we do it is we just take the joint out and put a screw. And if you look on the left, you can see that's an arthritic joint. On the right, we've taken the joint out and put a screw. And it stabilizes the joint and takes away the pain. For wrist arthritis, we've been talking about hand arthritis. What we do for the wrist, there's a number of options. There's an operation where we remove some of the bones. We'll sometimes partially fuse the bones. Sometimes we'll do a complete fusion, and very rarely we'll do a joint replacement for the wrist. Here's somebody with arthritis, and you can see on the left the red arrow. There's no cartilage there, it's bone on bone. If you look elsewhere in the wrist, you can see there's still good cartilage. The procedure that was done here was those 3 starred bones we took out, and on the right you can see we've created a new joint. And this operation works very, very well for pain relief. It maintains some motion, but you're not normal after this, and you end up with about a third to half of your normal motion. So this is a good option for somebody who has wrist arthritis with very specific findings. Here's someone who has wrist arthritis, which was where the arthritis was everywhere in their wrist. So we did what's called a fusion. And what this does is you take away the motion, but you get a stable wrist, which is painless. And again, you can imagine this is really a last resort. We do this when someone is really miserable. We don't do this very often. And most of the time when we do this, patients have tried everything else. So if you would like more information on arthritis, and specifically arthritis in the hand or wrist, you can go to the Arthritis Foundation website or the Johns Hopkins Medicine website, where there's information on arthritis. I'm going to switch gears now and just talk briefly about tendonitis of the hand and wrist. This is another big cause of hand pain and dysfunction that we as hand surgeons see frequently. I'm going to first talk about de Quervain's. De Quervain's is a very specific tendonitis which involves the radial side of your wrist, which is the side of your wrist that's just below your thumb. Patients have pain and swelling. They often will have limited motion of their thumb, and it's usually caused by repetitive use. And some people call it mommy's thumb, and we see it quite a bit in new mothers from lifting their children. I'll see it in the dads and the grandparents, and it's from the repetitive lifting. But we see it in people who are remodeling their houses or doing a lot of gardening or yard work. And it's a pretty common problem. So you can see in the two pictures, it involves the area just below your thumb. The tendons get swollen. There's a tight tunnel there, and they get irritated and stuck as they go through. The picture on the right is what's called a Finkelstein's test, which is how we diagnose this. And this maneuver causes pain and reproduces the patient's pain. The treatment for most tendonitis is rest and ice, immobilization, anti-inflammatories, and if all that fails, surgery. In terms of anti-inflammatories, we'll use Advil or Aleve sometimes, but most frequently, by the time these patients get to our office, we use a cortisone injection, which will often solve the problem. I quote patients a 60 to 70% cure rate with 1 or 2 or 3 cortisone injections. A wrist splint will also help. And when patients don't get better with injections, anti-inflammatories, splinting, activity modification, there's a relatively minor surgery that can be done. Relatively minor surgery that can be done that will solve the problem. Next, I'm going to talk about trigger fingers. Again, a very, very common problem, something that Dr. Moss and I see multiple times every day. Trigger fingers are another form of tendonitis. And the way I explain it to patients is it's like there's a knot in your shoelace as it goes through your sneaker eyelet. And so it snaps and pops. And so patients with trigger fingers will complain of night pain and locking of their fingers, morning stiffness, limited motion, and patients will come in and say, my finger's popping in and out of joint. And I often have patients tell me they're sure they have arthritis. And it's really a very straightforward problem, and we see it a lot. And this picture here shows the tendons and the pulleys which the tendons glide through. And in this particular index finger, you can see the very swollen nodule, and the tendon is getting stuck as it goes through there, and it pops and catches, and it's painful. And for whatever reason, it's worse in the morning and at night, and usually better as you use your hands. And so, again, the way we treat it is observation and splinting, anti-inflammatories, injections, and when that fails, surgery. And again, 70 to 80% of people are cured forever with 1, 2, or 3 cortisone injections. And this is probably one of the most common problems that I see, and one that we can fix fairly easily. The surgery, if it comes to that, is done under local anesthesia. You can go back to light things immediately, and usually by 3 or 4 weeks, you're back doing everything. So this is a very common and treatable problem. So I want to thank you for your attention, and I'm going to turn this over to Dr. Moss now. And again, the questions we're going to take at the end in the Q&A section. So I'll turn it over to Dr. Moss now.
That was excellent, Richard. Thank you, Dr. Barth, for that great presentation. My name is Dave Moss, and I work with Dr. Barth. We both work at Washington Orthopedics and Sports Medicine. And let me return to the beginning of my talk here. Excellent. So I'm going to talk today about carpal tunnel syndrome. I'm just going to talk about carpal tunnel syndrome, and I'll get into the specifics of this. Carpal tunnel syndrome, the talk today is going to focus largely on defining carpal tunnel syndrome. What is it? A lot of people come in with generalized hand pain and say, I have carpal tunnel syndrome, but carpal tunnel syndrome is really a specific set of symptoms that create a syndrome that we call carpal tunnel syndrome. I'll go over that with you in a minute. We'll talk about those signs and symptoms. So what are the specific signs and symptoms that constitute carpal tunnel syndrome? And then we'll talk about epidemiology, or who gets carpal tunnel syndrome, how do we diagnose it, and then how do we treat it. So hopefully you can see in this slide here, carpal tunnel syndrome is defined as compression of the median nerve at the wrist, and the median nerve is that yellow structure that you can see sort of fanning out into the thumb and the fingers. That's the nerve. And the nerve lives in a canal, the carpal canal or the carpal tunnel, which is also inhabited by the flexor tendons. And from time to time, swelling can occur and the nerve can get compressed in that canal. And when the nerve is compressed, it creates specific symptoms in the hand that I'll go over with you in a minute, largely numbness and pain. Here is a cross-sectional view of the hand where you can hopefully see at the level of the wrist, the yellow structure that's labeled median nerve. That is the nerve, and then there's many other structures in the carpal canal, and the carpal canal is made up by the bridge of bones or the arch of bones that you can see, those sort of yellowish structures. There's 6 of them in the bottom. And then the roof of the carpal tunnel is the transverse carpal ligament across the top. And if volume accumulates in the carpal canal, then pressure will increase, the nerve will get pinched, and you'll develop these specific symptoms that constitute carpal tunnel syndrome. So these specific signs and symptoms that are carpal tunnel syndrome, the easiest way to think about it is numbness and pain in the thumb, the index finger, and the middle finger. And often half of the ring finger is involved, as you can see in the pictures here. So numbness and pain in those specific regions, that's what makes us think about carpal tunnel syndrome. Wrist pain or numbness in the small finger or popping and catching, those are all hand problems that Dr. Barth and I can help you with, but those are not necessarily carpal tunnel syndrome. Usually carpal tunnel syndrome is numbness and pain in these 3.5 digits. Often patients with carpal tunnel also present with night pain, which means they wake up at night, sometimes shake their hand out to try to get rid of the pain, or hang their arm over the side of the bed, or do all sorts of other things to try to relieve the numbness and the pain. And that occurs at night typically. It can happen during the day as well. Patients often present with tingling or burning, where they feel tingling and burning in the thumb, the index finger, and the middle finger. Patients often complain of a loss of dexterity or difficulty with fine motor skills. So this can present with activities like trying to put earrings in, or pick up coins, or button buttons, or things of that nature. Additionally, loss of dexterity can present with dropping things like dropping glasses or dishes or things like that, which is a common complaint with carpal tunnel syndrome. And then often weakness of grip or weakness of strength can be a finding as well. And that can be associated with other conditions of the hand, including arthritis, but we look for a constellation of symptoms that constitute carpal tunnel syndrome. Now, who gets carpal tunnel syndrome? Carpal tunnel syndrome affects women more frequently than men. It's more commonly seen in obesity. Patients with diabetes or hyperthyroidism get it more frequently than most. It's commonly seen in pregnancy, and it often resolves once the baby is born. And carpal tunnel syndrome can also be seen in trauma or after trauma. So for example, if you break your wrist or if your hand is crushed, then there can be swelling in the hand or other scar tissue or things of that nature, and that can cause carpal tunnel syndrome to develop either acutely or right at that time, or even later at a later date. A common misconception is that typing causes carpal tunnel syndrome, and the medical literature to date shows that carpal tunnel syndrome is not caused by keyboarding or typing. keyboarding and typing can exacerbate carpal tunnel syndrome if you already have it, but the common thought process among the experts is that the keyboard does not cause carpal tunnel syndrome. At the end of the day, I went over a list of things that cause carpal tunnel syndrome, but truthfully, most cases of carpal tunnel syndrome at the end of the day are idiopathic, which means we don't have a specific cause of the carpal tunnel symptoms and syndrome. Regardless of the cause, whether we identify it or not, we can still identify the syndrome and we diagnose it, much like we diagnose everything in orthopedics or in medicine, by taking a history, which means we're going to talk to you, you're going to tell us your story, we might ask you a few focused questions and try to get to the bottom of things. We'll do a physical exam, which is generally brief and quite easy for the patient. And diagnosis also may include a nerve conduction test, which I'll get to later, which is not always performed, but sometimes it is, and I'll tell you what that's all about. So the history, this is often the patient telling us the story. And like I said, patients often complain of night pain. Numbness while driving is a common complaint where the hands are elevated up on the wheel. Numbness reading the paper, as you can see in the bottom picture, where again, the hands are elevated for extended periods of time. And this can include reading from a tablet or using your iPhone for extended periods of time. This can all create this numbness and pain in the fingers. And then often patients tell us about dropping things. The physical exam is usually fairly brief. We're going to feel your fingers and see if they're numb. We'll tap on your wrist, as you can see in the top left image. That's a test called Tinel's test. The bottom right image is where the wrist is flexed or bent. That's called Phelan's test, and we'll test bending your wrist down for about a minute, and we'll see if the numbness returns. And these are tests you can even do at home to some extent to see if you have carpal tunnel syndrome. We also might examine your neck briefly to see if the symptoms are coming from your neck instead of your wrist, which would be treated quite differently. Here's another example of that wrist flexion test called Phelan's test to see if you have carpal tunnel syndrome. And if you hold that for a minute and your fingertips go numb in these three fingers, then that might be consistent with carpal tunnel syndrome. A nerve study is a test performed by a neurologist or a physiatrist. It's different types of nerve tests are things like a nerve conduction test or an EMG. And these are not routinely performed, but from time to time we order these if we're confused about the origin of the symptoms, such as if they're originating from the neck or the hand and wrist or any place in between. And this will help us understand what's going on a little better. But again, they're not always ordered. It's a case-by-case scenario. So how do we treat carpal tunnel syndrome? Carpal tunnel syndrome is generally very easy to treat. Most people that present with carpal tunnel syndrome to our offices are going to walk out with a splint, much like the one you see before you here. A simple Velcro splint that we ask you to wear at nighttime when you sleep, and that prevents the wrist from falling into that flexed position, which pinches the nerve and causes the pain and numbness to develop. The splint is only worn at night, and it prevents your wrist from flexing, which is how most people sleep. It keeps it in the neutral position, which is much better for the nerve, doesn't pinch the nerve. And most of the time with this simple splint for about a month, the symptoms resolve. Sometimes we will ask you to modify your activity. So some patients present saying that I've been working on my deck all summer and my hands are now going numb. And if that's the case, and working on a deck is a hobby but not your occupation, then maybe we can change your activities a little bit so that you're doing something else that you enjoy without aggravating your carpal tunnel. And it may be as simple as changing your hobbies or changing your activity to get rid of those symptoms. A wrist injection is sometimes performed. Dr. Barth talked about this. Orthopedic surgeons generally like cortisone. It works for a lot of things, at least to some capacity. It can work for carpal tunnel syndrome. Sometimes it helps us define the diagnosis or helps us come to a conclusion on the diagnosis if it's somewhat confusing with the history and the physical exam. Sometimes it will perform an injection and it will provide temporary relief of carpal tunnel syndrome. Sometimes we will perform an injection and it will provide long-term or permanent relief of carpal tunnel syndrome. So it certainly has a role in treating carpal tunnel syndrome, and we would decide whether to perform an injection on a case-by-case basis. If the splint and the injection and modifying your activities are not successful at relieving carpal tunnel syndrome, then we often recommend surgery. Much like the surgical procedure Dr. Barth described for trigger finger, carpal tunnel surgery is very straightforward for the patient and relatively simple as far as surgeries go. This is an example of what's called an open surgery with a relatively larger incision. This incision is probably 3 or 4 times the size of the incision we use for the open surgery, but it does show the anatomy fairly well, and it shows the structure that the surgeon's knife is on is the transverse carpal ligament with the yellow nerve beneath that. And once the transverse carpal ligament or that thick white ligament is released, then there's room for the ligaments and the tendons to expand and the symptoms go away. Frequently, symptoms like waking up at night or numbness at night and pain at night go away immediately after surgery. And it's not infrequent for a patient to say that their symptoms resolved immediately and they got their best night of sleep in years and slept through the night for the first time in years. So the surgery can be very successful. From time to time, we'll choose this endoscopic surgery instead of the open surgery. You can see it's a smaller incision where we perform a small keyhole incision in the wrist and then slide this device, which has a camera at the end, and we can do all the work you saw on the previous slide through that small keyhole incision. And the recovery is a little bit quicker with the endoscopic surgery, but the end results are the same whether it's open or endoscopic. After surgery, whether it's open or endoscopic, patients walk out with a little light dressing that is very similar to what you see here in the picture. No splints, fingers are free. You can go back to keyboarding and typing. And because the surgery is rather minimal, we recommend that patients remove this dressing about 3 days after surgery and come back a week later to take the stitches out. So it's a small surgery that's very effective. I should add that the surgery, or treatment I should say, of carpal tunnel syndrome is time sensitive. This is not something you want to sit on for years and years and years and present to Dr. Barth or myself and say, I've had these symptoms for 10 years, what can you do for me? This is a condition that's much better treated if it's treated acutely or shortly after symptoms have developed, because you can have a much better result with much better relief of your symptoms if we get to it sooner than later. So don't sit on carpal tunnel. If you think you have it, please come for a visit. So what should you expect? This is sort of a summary slide. If you come to the office, you should expect to talk about your symptoms or have a discussion about your symptoms where you present your complaints or your issues, and we might ask you a few directed questions to get more information. That's called our history. You can expect a short exam. We went over the Tinel's test and the Phelan's test and maybe a brief neck exam as well. Sometimes we'll order a nerve test. That will be ordered and we'll review the test at a later date if that's necessary. And most of the time you're going to walk out with a splint. If your symptoms are severe, if we think your nerve compression is severe, which is not simply a reflection of your complaints or your symptoms, but often more of a diagnosis based on examination and sometimes even a nerve study. If your symptoms are severe, or if you haven't had relief of symptoms with a splint or activity modification, then we're going to talk about surgery, which, as I demonstrated before, is pretty straightforward and easy as far as surgery goes and quite effective. So thank you for your time. Thank you all for listening to us on this Zoom format, which I know is different than the live seminars we've had in the past, but hopefully it was effective and we're still able to teach a bit and you all were able to learn a bit about these conditions of the hand. And we're going to open it up now to a question and answer, which I see a couple questions there. Dr. Barth is going to help moderate this part, and please keep your questions general. If you have a focused or specific question about your own condition, then I'd ask that you please see us in the office about this. But if it's a general question about arthritis or the tendonitis conditions that Dr. Barth discussed, or carpal tunnel syndrome that I discussed, then we'd be more than happy to discuss it in the forum. Dr. Barth, all you.
So I only see two questions. One question says, X-ray doesn't show arthritis, and I don't know if there's more to this question. So if you are, Marie, maybe send in that question again.
I can answer that, Richard. There was a slide that didn't present during your talk, but it came up later, and I think that it was resolved. So
oh, okay.
I think that's what I was alluding to. Just one slide didn't forward for some reason.
Okay. So it says, I have arthritis in my shoulder, pain in shoulder and upper arm. Is treatment the same as for the hand and wrist? I'm using Voltaren. Dr. Moss, you want to handle that one?
Sure. Arthritis is generally treated very similarly, at least in the early stages. So we use the acronym RICE for rest, ice, compression, and elevation. That's an easy way to treat most conditions. Put some ice on there. We often prescribe anti-inflammatory medication, or you can take that over the counter for most conditions. Resting joints like a shoulder or an elbow that's arthritic in a sling or splint is often helpful. So Dr. Barth covered most of those things for his arthritis talk. Once you get beyond that, if things don't, if your symptoms aren't resolved, a cortisone injection may be helpful for shoulder arthritis as it is for the wrist. And then if you get beyond that, surgical treatment, the principles are the same, I would say, but the specific surgery is different for each joint. So that would be a different discussion, I think.
Thank you, Dr. Moss.
Add to that?
No, I think you've covered that. I'm good. The next question is, did you discuss the value of glucosamine and chondroitin? And I think I did, but I will touch on it again. There is not a lot of very good data that shows that glucosamine and chondroitin provides any long-term relief. There are a number of studies that show it may help a small number of people, but it's not very different than placebo. And so there's not a lot of good data that shows it works, but my experience is that about a third of patients find it very helpful, and it seems to provide some benefit. And since I don't know of any side effects or complications from taking glucosamine, I think it's a reasonable thing to do in somebody who's willing to try it and be honest with themselves. And if it helps, take it. If it doesn't, then I would stop it. So that's what I have to say about glucosamine. Dr. Moss, do you have anything to add to that?
No, I think that's good. Yeah, it's got a role, but it's not our first line.
What can you say about Heberden's nodes and Bouchard's nodes? I will take that one. So Heberden's nodes and Bouchard's nodes are the bumps that you get on your fingers when you get arthritis. And I think I showed a picture of somebody with arthritis in their hands. That may have been the one that didn't come through. But there's bumps and nodules, and those are called Heberden's nodes if they're at the end joints, the DIP joints, or Bouchard's nodes at the PIP joints, which are the joints closer to your hand. And they're just a sign of arthritis. And I don't know if that answers the questions, but that's what those nodes are. The next question is, how many trigger finger injections can a person generally tolerate? And Dr. Moss, why don't you take that one?
All right. Usually we try to do maybe 2 or 3 shots. I think some very critical studies show that 2 is the appropriate number. Some show that 3 is the right number before they just don't really work anymore or they lose their utility. You can probably do a little bit more on occasion. We've all injected somebody a 4th time or a 5th time if they've got extenuating circumstances. But usually after 2 or 3, if they don't work, we recommend the surgical procedure, which Dr. Barth alluded to. It takes about 15 minutes. It can be performed under local anesthesia, but too much cortisone a specific area can cause harm. So we do try to limit those and be judicious.
I agree completely. The next question is, I am a 68-year-old male who developed pain in my right thumb after a heroic effort at weed pulling in my vegetable garden a couple of months ago. Splinting and anti-inflammatories have made the condition better, but it is still evident. One thing I noticed is that there's a clicking in the thumb joint now. What does that indicate? I'll take this one. It can indicate arthritis. It could indicate a trigger finger. Those would be the two most common things that I would think of with the story that you've told me. But without an exam, it's hard to be sure. So the next question is, what can be done to reduce or eliminate Heberden's nodes and prevent them from appearing on other fingers? Treatments, exercise, diet, ? Dr. Moss, I'll turn that one over to you.
Yeah, I think the nodes, there's not a whole lot we can do to prevent them. Dr. Barth mentioned in his talk that a lot of this is genetic, or it's just going to happen for certain reasons. There are things you can apply, like topical gels, topical anti-inflammatory gels, which may reduce inflammation to some degree. There's no exercise that will help arthritis. Arthritis is a wear and tear condition, so using the joint more and more is going to inflame the arthritis instead of reducing the inflammation. So oral anti-inflammatories, ice, rest, things like that may help a hot, inflamed joint settle down. But if you have a painless joint that happens to just be swollen or have those nodes in it, I typically recommend using it and enjoying the joint. It works. And if it looks a little different to you, I think usually a joint that works is not noticeable to other people. So I would just enjoy a joint that works well. And if it's simply a cosmetic problem, sometimes the gel will help a little bit.
Okay, thank you. The next question that I have is, are there known and preventable causes of trigger finger? The answer is, there are probably a number of things that contribute to trigger fingers. I would not, aside from not using your hands, I don't think there's a lot of things you can do to prevent getting trigger fingers. I think that there are certain activities which predispose you. If you were operating a jackhammer, you're playing a ton of golf, you're doing a lot of weeding, repetitive gripping and grasping, but there's nothing that I would say that I would change my life over if I had a trigger finger, because I think the treatment is pretty straightforward, and I wouldn't give up using my hands. And I don't really think there's any particular thing that we know that causes it. Patients who have diabetes are more likely to get trigger fingers, but obviously you can't change the fact that you have diabetes. So I think it's one of those things that's very, very common, and I think you deal with it. The next question is, I have synovitis in my upper hand, which limits mobility in the wrist. Is this related to arthritis? So, Dr. Moss?
Synovitis is inflammation in the tissue called the synovium. So that can be tissue that lines sort of the tendon sheath, or it's present in joints as well. So the specific answer depends on where your synovitis is, but synovitis can be problematic. If it's around tendons for an extended period of time, it can irritate the tendon or even cause the tendon to rupture. So if you have synovitis, I'd recommend you come in and get a visit with one of us, and we can take a look at it and figure out how to get rid of it, which sometimes could be a cortisone shot or a number of other things to try to eliminate the synovitis and help your function return to normal.
Thank you. The next question is, I have had de Quervain's surgery in my right wrist, but not my left, which was treated conservatively. The start of the two tendons in my left thumb still hurt for over a year. Is that still de Quervain's? So I think what you're telling me is that you've had surgery on one side, and that you have some problems on the other side, and it was treated conservatively. And it sounds like from your description, you still have a little bit of tendonitis there, but obviously without examining you, it's very difficult to definitively make a diagnosis in this forum. So the next question, oh, here we go. There's it looks like an addendum to this. Specifically, when my extensor pollicis brevis, always hurts. The part that is visible when I raise my thumb. Again, this sounds like you still have deep veins, and it may benefit from treatment. So the next question is, my trigger fingers, quote, trigger, unquote, almost every time I bend it. A previous cortisone shot brought relief. Am I making it worse by putting off getting another cortisone shot? Dr. Moss?
Yeah, I think that for trigger fingers, I think you are making it worse by putting off an injection. So the more you flex it and the finger gets stuck, it'll cause more inflammation in that area and cause the finger to get stuck more and more. So for a trigger finger, sort of like my plea for carpal tunnel syndrome, if you have trigger finger, getting in there a little bit earlier than later is going to help your prognosis, help you recover better. And if you let it go for a long time, it's a little bit harder to treat. So I would recommend getting treated sooner than later for trigger finger.
I agree completely with Dr. Moss. The next question is, what is the success of carpal tunnel surgery? And I'll let Dr. Moss answer that since that was his talk.
Carpal tunnel surgery is very successful. I don't have the numbers in front of me, but I would say, depending how you define success, I think people are improved 90+% of the time. The people that, not everybody gets full recovery, so your wrist may not return to whatever your hand was when you were 20 or 25, but that can be dependent on how long you've had the symptoms or how severe the compression is, or if there's like an associated cause, like if you're diabetic or if you've had a trauma or a fracture that caused the carpal tunnel syndrome. But most people have a very successful result, like I said, with relief of symptoms for many people the very first night after surgery. So the numbers are above 90% for improvement and success.
I agree with Dr. Moss. If I had to have one problem that I take care of, it would be carpal tunnel syndrome. I think the surgery is extremely effective, and it's a very, very straightforward procedure, and people get better pretty quickly, assuming you don't wait too long. The next question, and I think this must be related to the other question, what about hyaluronic acid? And I think if the question is how effective is it in the wrist and hand, I would say that there's not data to support that it's effective in the wrist and hand. I've had patients anecdotally tell me that it helps them. I don't think it hurts you. So I have on occasion injected people who've requested it, but there is not good data that it works well in the hand or wrist for arthritis. And if this is related to carpal tunnel syndrome, it has no indication in carpal tunnel syndrome. The hyaluronic acid, it works well in the knees, and I think that's the principal use. Do you have anything to add, David?
No, I agree completely. I did notice, Richard, that there's a couple questions in the chat box that I can pull up here.
Why don't you take care of those, because I don't know how to do that.
Okay, one is, the first one is from Jeff Monk. Hello, a little shout out. He says, what kind of injuries are likely to cause arthritis? Richard, would you like to address that one?
I think the injuries that cause arthritis are injuries which damage your joint. So the classic probably injury is an ACL injury in the knee, for example, will often predispose you to getting arthritis because of cartilage damage. If you're talking about the hand and wrist, something like perhaps a fracture, dislocation of a joint, a torn ligament in your wrist or your hand, a fracture that goes into your joint, we call that an articular fracture. those type of things could cause damage to the cartilage. So anything where you could damage the cartilage is something which may result in arthritis down the road.
I agree. I agree. Well said. There's a second question here in the chat box. Carpal tunnel surgery for scleroderma patients and healing of skins. This is a specific question. Scleroderma is a condition where the skin gets very thick. The soft tissue can get very thick and infected and cause contractures, and other problems are associated with it. That is a specific condition that I think that the data, the numbers that we presented for success for carpal tunnel syndrome may be less successful for scleroderma patients, but if the nerve is compressed, nonetheless, the etiology of releasing the pressure on the nerve, that etiology, if that's the same source, then the treatment is the same. So same treatment if it's in fact carpal tunnel syndrome for scleroderma. Anything to add to that, Richard?
No. I think carpal tunnel surgery and scleroderma, I think, would be very effective, and I don't think the scleroderma would impact it too much. So do you have other questions there in the chat box, or should I go back to these?
No, go back to the Q&A. I think we've wrapped up the chat box for now.
Is there anything you can take or do to build up the cushion between the joints or to keep it from diminishing? I will take that. The answer is really no. Right now, we have no way to rebuild cartilage. Once you lose cartilage, it's gone. There is a lot of research going on right now in terms of regenerating cartilage, but today I can't tell you there's anything that we can do to regenerate cartilage once the cartilage is gone. So I think the key is when you start to lose the cartilage, you want to do the things that we discussed to try to keep yourself from losing more cartilage. And whether it's splinting, activity modification, sort of taking it easy on your hands, I think those are the things that you can do. But there's no way to rebuild the cartilage at this point in time. The next question, and I'll turn this over to Dr. Moss, can PT help carpal tunnel syndrome?
Therapy, we have special hand therapists usually that we use, occupational therapists or hand therapists, very similar to physical therapists. Sometimes therapy can help carpal tunnel syndrome. I guess it could cause it too from time to time, but usually if it's going to help with carpal tunnel syndrome, it's if they're helping you modify your activities or change your behavior in a way that inhibits the pinching of the nerve, the way you use your hand. Sometimes they can also do things called nerve glides, where they help the nerve slide in its sheath a little bit easier and its tunnel a little bit easier, and helps diminish symptoms. So there is a role for it. I think it's not the cornerstone of treatment, but sometimes there is a role for it.
Thank you, David. And I think this may be the last question. And it says, can prolotherapy with platelet plasma injections work for thumb arthritis? And I think the question is referring to plasma, platelet-rich plasma, and prolotherapy. So there are, in our zeal to avoid surgery and to come up with new ways to treat arthritis without surgery, there's a whole new industry out which is using regenerative or alternative ways to treat arthritis. To my knowledge, there is no data that supports prolotherapy for thumb arthritis. I think anecdotally, again, there's probably some patients where it may benefit them, but I think a large series, which is well done, which compares people who got prolotherapy to people who didn't, I don't think there's data that shows that prolotherapy is effective. I think the same is true with PRP, or platelet-rich plasma. I think that there are theoretical reasons why that may help, but I don't think there are good studies that clearly document the benefit. I think the nice thing about both of these things is I know of no significant risks to doing it. The biggest issue is that they're expensive and they're not covered by insurance. The other thing that's sort of out there now is using stem cells again. Theoretically, there's hope that these things might help, but again, there's really no good hard data that these alternative treatments provide any long-term benefit. And I don't know if you have any other words on that, David, as that's, a lot of that this is some new stuff.
Yeah, I agree. On the same lines, I would just add a lot of people asking about CBD creams and oils, and there has been some literature about CBD, which is sort of marijuana-derived products that are thought to reduce inflammation, and there actually have been some good studies on that show that it's really no more effective than some of the tools we have at our disposal now, like anti-inflammatories, traditional anti-inflammatories like ibuprofen, or some of the topical gels we use like Voltaren gel or Pennsaid gel, which provide similar or superior symptom relief to CBD cream. But I think the idea of looking for something that alleviates symptoms is noble, but we're still looking for what's out there, trying to get something better than what we have at the moment.
Yeah, the only thing I would add about CBD is, again, it's that I've had a few patients who tell me it seems to work for them. I think there is very little, if any, risk to putting CBD cream on your thumbs. And so I have no objection or problem with someone trying it. I think, again, the downside is the expense and the fact that it's really not been shown in scientific studies to provide any long-term relief. But that doesn't mean it may not help a few people. And again, personally, patients ask me about this all the time, and I have no objection to patients trying it. I think that's the last question, unless we have any further questions. I think I'm going to call it a night, and on behalf of Dr. Moss and I, thank you very much for joining us, and hopefully we've taught you something and answered your questions. So have a good night.